comes to principles of surgery, there are three main principles that any surgical team will follow. One is to reduce the intake, that is restriction of the food by restricting the size of a stomach. Second is malabsorption. By doing metabolic surgery, bypass, we make the absorptive capacity of the intestine come down by at least 1/4. So, by decreasing the assimilation and storage of the nutrients. Third, to increase your satiation, that is by decreasing the hunger as well as increasing the feeling of fullness. So, by restriction, malabsorption and satiation, you work on these three principles for bariatric surgery. And these patients work on three major principles. Foregut theory is the most commonest theory which works in every single bariatric patients. This helps in restriction of all the restrictive procedures. When you do a normal GI tract eating, the X or A cells of the stomach secretes ghrelin. This ghrelin will have some impact on the duodenum and increases the secretion of what we call as a incretin group of hormones. And the majority of stomach is removed in a bypass or a sleeve where this ghrelin secretion comes down. So, they reduce the appetite by reducing the ghrelin factor as well as incretin secretion is not restricted. This leads to weight loss as well as improved glucose tolerance along with the reduction in the volume as well. So, you reduce the volume of a stomach by reducing the size of a stomach, reduce the appetite, causing weight loss by these two means, and improves the glucose tolerance. Based on this, there are few procedures which has been postulated. One is gastric band, where you put a band around the proximal part of a stomach, which is about 2 centimeters from the GE junction, and this has a balloon tube around the neck, tube and a port which comes under the skin. So, you put in saline through that skin, you put a saline through that, and water or saline goes through it and fills the balloon inside and then gives a restriction by constricting the neck of the stomach. This reduces the volume, which is going to be 25 cc, and that way it helps in reducing the intake. The second is called sleeve gastrectomy, where stomach is around 500 to 650 cc, which is reduced by 3/4. We make a sleeve with a 80 to 100 cc pouch by stapling and removing the lateral part of a stomach. This becomes a vertical sleeve. Then we have gastric bypass, where the stomach is cut into a 25 cc proximal gastric pouch, transection of the distal pouch, and then they do what we call as a bypass of the proximal jejunum by transecting around 75 centimeter below the ligament of Treats and anastomosing it to the stomach. So, the food that enters comes from the stomach into the distal jejunum and goes down, whereas all the gastric juices, bile and pancreatic juice comes and joins around 75 centimeter beyond the DJ flexion. So, this is typical of a Foregut theory.